Assalamu alaikum. Good afternoon, everyone. Good morning, actually. We're still good morning. First, allow me to thank you for having this opportunity to present my talk today. My talk will be about malignant bone tumors in children. The topics that I will be covering today is the one you see in front of you. We'll talk mainly about introduction about the malignant bone tumors in pediatric population, osteosarcoma, Ewing sarcoma being the most common, and going through some of the insights about how we proceed from diagnosis to limb salvage surgeries. To start, pediatric malignant bone tumors are very rare. And it's well known that a multidisciplinary team and coordinated teamwork is essential to provide the best possible outcome for those children. It's never a one-man show, and it only works through a team collaboration. The two leading primary malignant tumors in children are the Ewing sarcoma and the osteosarcoma, and Ewing sarcoma family and the osteosarcoma. Osteosarcoma and Ewing sarcoma family of tumors are the most common malignant tumors in children. We face them. You have to have high index of suspicion when you see them. While significant improvements have been shown in the survival of those tumors, yet with very good outcome, yet over the past 3 decades, nothing has almost changed in the diagnosis and the treatment. They are almost the same. We're doing the same. The only advance that happened is the improvement in the chemotherapeutic agents and the targeted therapy that improved the prognosis and the outcomes of survival. To start, I will start with an osteosarcoma, talk about it. It's the most common primary malignant tumor in pediatric population. The incidence is 1 to 3 per million with a slight male predilection, okay? Histologically, they are spindle-shaped cells, but characteristic of it is the malignant osteoid. The preference is usually around the knee, mostly in the metaphysis, mostly distal femur, proximal tibia, and proximal humerus being the most common sites of osteosarcoma. It rarely occurs in children below 5 years of age. However, in this case, we have to diagnose it, we have to confirm it. It's usually associated with some syndromes or genetic mutation, but the common is usually starting from the 2nd decade of life. Osteosarcoma metastasize mainly to the lungs, okay? Second to the lung is the bones, Here, there is a difference in literature as reported. Some authors report that 10 to 20% have already pulmonary metastasis at initial presentation, where other reporters indicate that 85% of patients with osteosarcoma do have micrometastasis at time of initial presentation, which is a very high number. By the time you first see your patient, he's already in metastasis, because now the new concept is it's a systemic disease rather than localized disease. The long-term survival yet, although this aggressiveness of this disease is very good, and the survival rate ranges between 60 and 70, and in some reports up to 85 and 90% survival rate with proper diagnosis and proper therapy. This is the difference. Okay, we diagnose the patient with osteosarcoma. We know the protocol. What can we change? This is the question that we need to ask. This is what we are looking for the modern medicine. The problem is now with giving the subtype and the right medical treatment, the right chemotherapeutic agent to the right subtype and subcategory of osteosarcoma to get a good prognosis, to get a good responder tumor. So, in the recent decade, there was high throughput sequencing has become the essential instrument in the biomedical science and is used for prognosis, forecasting, cancer recurrence, monitoring, and clinical stratification, since it has been important to apply osteosarcoma and identify possible key targets for therapy. On the other hand, Ewing sarcoma is the 2nd most common pediatric tumor, and it has multiple variants with skeletal and extraskeletal and ewing sarcoma of the soft tissues. We need always to understand that once we mention ewing sarcoma, we have to bear in mind, especially pediatricians and general practitioners, osteomyelitis, acute osteomyelitis. You can never separate these two names. It's very confusing. The clinical picture are the same. The presentations are the same. Radiology is sometimes very confusing. MRI, even more confusing, and up to the histology. And I will tell you why. It is the second most common. The incidence is 2.5 to 3 per million. Most frequently seen, as we mentioned, osteosarcoma prefers around the knee and metaphyseal areas, whereas ewing sarcoma prefer shafts, diaphyseal areas, and axial skeleton. So the preference sites would be shaft of the femur, shaft of the tibia, shaft of the fibula is very common, and in the axial skeleton, pelvis is very common, scapula. These are the most common sites of ewing sarcoma. 20% arise in the soft tissue. Okay. Histologically, they present with distinctive small round blue round cell tumor, which is actually confusing the histologist with lymphocytes. If there's an infection, they are small monotonously round cells, the same. That's why it's very confusing even in biopsy. There is the causes sometimes related to the translocation of some of the genes. The treatment would include classically chemotherapy and radiation therapy. Osteosarcoma is basically chemosensitive only. Ewing sarcoma is both chemo and radiosensitive. But the mainstay in treatment would be adjuvant therapy plus surgical resection for limb salvage if in favorable condition. The overall survival rate reaches to 85%, which is very good. Still, we have high incidence of metastasis. About 27% of the patients do metastasize. The clinical diagnosis of any malignant bone tumor not only increase the chance of survival of the patient, but also increase the possibility of rendering this limb salvageable. I can save a limb, I can save the quality of life of a patient with proper early diagnosis of these patients and performing the right therapy and when I say therapy, it's a combined medical treatment and surgical treatment. It can never go one way. How we diagnose? What is the clinical presentation of any child with malignant bone tumors? Pain is the most common presentation, and pain is the thing that drives patients to the doctor, not the swelling, okay? It can be intermittent. It can be constant without relief, not responding to non-steroidal anti-inflammatory and painkillers, always related to activity, and worsen at night. And why is that? Because it is all related to intraosseous pressure and congestion. With more activity, more blood flow, more congestion, and at night with the muscle relaxation, more congestion, and that is why all inflammatory pains worsen at night. And the same, but it's very significant in malignant bone lesions that is worsen at night markedly. It wakes and disturbs sleeps. And this is an alerting sign. It's one of the red flags. You need to pay attention well when a patient presents with that, and you need to ask it very specifically. Does this wake you at night or no? A lump could be present, but it's not necessarily. Sometimes cannot be reached, especially if a pelvic tumor is there. As you can see here, we can see here, there is a swelling in the thigh, and we have to compare. If you don't compare, you don't see. This is the same patient. Can we see here? This is the swelling on that right thigh, and compared to the left thigh is not seen. So the comparison, you cannot diagnose what you can see. This is how an osteosarcoma could reach. This is a devastating case where this young girl, she's 15 years old. Unfortunately, she passed away. She had severe form of non-responsive osteosarcoma. And one of the things that we need to understand, sarcomas do not fungate. Okay? The necrosis we can see on the skin is pressure, ischemia and pressure sores from the immense size of the tumor, and this is when a chemotherapy is not responding. They can present with pathological fracture, where it weakens the bone. And what is the definition of pathological fracture? It's a fracture that occurs without any substantial trauma or physical effort that causes, where the bone cannot withstand the normal physiological load it is used to bear. Then it breaks, it fails. It's mandatory to make a differential diagnosis with infection, as I mentioned earlier, because they both present, and it's very classic scenario, especially with Ewing sarcoma. They present with fever, swelling, redness, hotness, and the mistake here, and the really alerting thing is, Ewing sarcoma have a very characteristic pattern of remission and exacerbation, where the tumor rises in activity and then completely subsides. So if a physician gives antibiotic and the tumor goes into remission phase, he would mistakenly think that there is a response on treatment. Once the exacerbation phase comes back, I should question myself once and twice. I should have that suspicion, because I cannot mistake something like this. I would lose a patient. And I cannot do anything, like the patient we have seen. Once it went out of control, you have nothing to do. You cannot do anything. Can you see this MRI? This is an MRI. Classically, if I don't think of osteosarcoma in this, I would be mistaken. But this is a case of infection, by the way. And see how confusing the clinical picture is. There is a rarefaction of the bone, extra-osseous component and cortical breach, intramedullary extension, which is very long, characteristic of the easy pathway of tumor growth, extracapsular, and you can see pushing the software and central necrosis of a tumor, and very hot PET CT scan. So this is a case of osteosarcoma, but this is a case of acute osteomyelitis. That's how we get confused. So we need to compare them. Always keep this in mind. Ewing sarcoma, infection, Ewing sarcoma. So how to suspect a malignant tumor on a radiologic basis? Thank God there are some characteristic features of benign and malignant tumors. Let me share with you some insights here. Benign lesions usually tend to have well-defined sclerotic border with solid periosteal reaction, what we call geographic pattern of bone destruction. Whereas in the malignant ones, they are rapidly growing, so they breach the cortex. There's interrupted pattern of periosteal reaction, what we call bone destruction, moth-eaten bone type of bone destruction, sometimes soft tissue extension, and wide zone of transition. You cannot see a demarcation. There is a very nice classification. It's called Ludwig Classification. I'm sorry, because this difference in the diameter of the screen were from the original presentation. That's why the letters are scattered. This Ludwig Classification have three main classifications. Type 1, 2, and 3. Type 1 is the sclerotic or the geographic pattern of bone destruction. What do you mean the geographic? Like a map. You can draw it with a pen, but it has either very thick sclerotic wall, which indicates very, very slowly growing tumor, or distinct, well-defined, but not very sclerotic, or indistinct, but well-defined. Whereas the number 2, type 2, is the moth-eaten type, which is a characteristic of malignant tumor. There is no pattern of the tissue itself, osteolytic, osteoblastic areas, and the permeative, where you don't know where the tumor started or ended. If we have a look on those pictures now, see those? I can draw exactly a pen. So this is Ludwig type 1, it's geographic pattern of bone destruction. This is type 2, it's well circumscribed, but not with clear sclerotic margin. This is well circumscribed, it's something, this is giant cell tumor here in adult, but you can see the outline and where the tumor starts and where it ends. Here, where is the tumor? It's everywhere, and there's an extra osseous component. I cannot see the cortex, I cannot see where can I draw. And this is the moth-eaten, and this is the permeative. Can you tell me exactly where can you see the end of the tumor? You cannot see. So these are the pattern of bone destruction, which helps us suspect from an X-ray what we are expecting. I just want to go faster with the type. All these at the end will end up in staging. We need to find staging. In musculoskeletal tumors, we have staging for the benign and malignant. I'll talk today about the malignant ones, which is 3 stages, stage 1, 2, and 3. Stage 1 and 2 each is classified into A and B, intracompartmental or extracompartmental. So a tumor inside the bone is intracompartmental. Breaching the cortex with extraosseous soft tissue, it's extracompartmental. 1 and 2 is for low grade and high grade. So it's a chondrosarcoma, low grade, so it's chondrosarcoma is type 1, intracompartmental A, or extra is B. Osteosarcoma is a high grade malignant tumor, so it will be 2, either A or B. By the way, usually in 26 years of practice, I have never seen type A osteosarcoma intraosseous. I have never seen it. Always presenting with an extraosseous extension. Okay. Type 3, it's either A or B, but with a distant metastasis. So it's high grade or low grade with distant metastasis. Okay. These are the types of surgical margins. Based on what are we going to do? The types of margins surgically we do is we go inside the tumor and intralesionally and resect it. We take the tumor from the capsule, which is the marginal resection, or which is recommended here in the malignant tumors, wide surgical resection with what we call a normal cuff of tissue. Normal safety zone. Normal tissue is excised with the tumor to maintain safe margin. The radical is the entire bone, entire muscle from origin to insertion. It's radical. When I talk about limb salvage, I prefer to choose this very symbolic picture because it's never one-man show. It's a teamwork. If it's not a teamwork, it never works. Limb salvage is an entire process from start to end. This is this is another case, but this is one of very, very challenging cases. This man has 10 years of suffering with 13 recurrence of his tumor. It's dermatofibrosarcoma protuberans. It's very low grade, very recurrent, 50% recurrence rate of malignancy. And that, what we did for him is surgical procedure designed to accomplish successful resection of the malignant tumor from the bone and soft tissue with restoration of skeletal continuity, reconstruction of a viable limb with acceptable oncologic, functional, and cosmetic outcome. This is exactly what we did. It's entire tumor resected with part of the bone, with part of the tissues, nerves, and reconstruction of a vascular bundle, reconstruction of a very thick skin flap, entire arm, and restoration of function. That's what we call a successful limb salvage, whether for bone or soft tissue tumors. Every patient with malignant tumor of an extremity should be considered for limb salvage. He is a candidate unless proved otherwise. If the tumor can be removed with adequate safety margin, let's proceed. A limb is worth saving if it's with acceptable degree of function. I don't save a useless limb that he will drag behind. Minimal amount of pain. I cannot give him neuromas and he will suffer for the rest of his life. That he will seek amputation later on. Needs to be durable, withstand the demands of activities of daily living. Otherwise, it's not a limb salvage. Amputation. It's one of the best of the worst mutilation ever done to the human figure. That was a statement stated by one of the authors in 1935, and still there. This is a mutilating picture. This is something heartbreaking. We should not end up like this. We should work hard to achieve treatment to save these kids from such a miserable fate. In the early 90s, amputation was the solution, was the only option. Now, quarter of these patients were candidates at that time for limb salvage, and nowadays limb salvage is successful in 90 to 95%, luckily, and thanks for the science and advances in chemotherapeutic agent and surgical resection of tumors and limb salvage surgeries. It has replaced amputation, and sarcomas now are a treatable disease. We cannot see sarcomas as we have seen them 30 or 40 years back. Amputation is only done for exceptional cases. So to do a limb salvage, advanced imaging and therapeutic agent should be there, including the dramatic change had led to this advancement with high techniques and high resolution imaging with precision of chemotherapeutic agents and radiotherapy agents. These have led to dramatic survival of patients. Teamwork and multidisciplinary teams and multidisciplinary tumor boards that advise and together reach a consensus to treat those patients with including multiple teams from orthopedic oncologists, medical oncologists, radiation oncologists, histopathologists, radiation, special radiation, musculoskeletal radiologists, clinical psychologists, and medical and radiation and clinical pathologists. All a team, a comprehensive team, all those who are involved in the treatment of those patients. So wide surgical resection is the mainstay now of how we are going to do limb salvage. This is the standard treatment. And nowadays, the most recent advance is how to reduce the safety margin. We used to do 7 centimeters safety margin in the earlier days. Now we reduced it to 5 centimeters. And now the new sciences are challenging for some low-grade malignant tumors to reduce it to even marginal resection with proper chemotherapeutic, cryotherapeutic agents to reduce, because my target is to remove as minimum normal tissue as possible with complete excision of all pathological tissues. That's the target that should be achieved. So before we do a decision, whether amputation and limb salvage, let's agree on something. In children, the accommodation and the adaptability of those children is super amazing. They will survive, they will do a lot, and they will have a very, very productive life. But we need to consider a lot of things. Considering especially in limb salvage and in very young age, limb length discrepancy. So one of the challenges we are facing in limb salvage surgery is if we replace a limb with a synthetic or metallic prosthesis, it's not going to grow. A child with 8 years of age, he's got about 10 more years to grow with growth spurt. I will end up with 20 centimeters difference. I cannot compensate that biologically. How many surgeries he's going to go through? So we need to be reasonable. It's not, yes, I am enthusiastic about limb salvage, but I have to be reasonable. Studies shows that the oxygen, they measure it with oxygen consumption. Oxygen consumption with below knee amputation is comparable to those with limb salvage surgery. So actually they are the same. The quality of life in those patients are almost more or less the same. We're talking about acceptability, about cosmetic, about psychological satisfaction. These are very important factors, but we need to think about, if I'm going to do a limb salvage surgery in a lower limb that will require 4 revisions, I would be hesitant to do that limb salvage surgery. If I have an expandable prosthesis that would cover a length as expected limb growth, yes, it's there's expandable prosthesis. I will show you it. But we need to always wait our patients for the first, number one priority here is different than any other priority. It's patient survival. I don't look anything. Number one for me is patient survival. This is how we should think. Number one, survival. Number 2, function. Number 3, cosmosis. So I'm not here as a plastic surgeon. I'm here as an orthopedic surgical oncologist. I need to do what's best for the patient in terms of, first, survival. Number 2, function. Number 3, cosmetic appearance. Yes, I should look for the long-term survival of the patient, as I told you, and psychological adjustment. Remove all the tissues that needs to be removed and share the disease-free. The steps is 3 steps basically: resection, skeletal reconstruction, and soft tissue coverage. These, if I fail to achieve any of those steps, or I will not be able to achieve it, limb salvage is not possible. The either reconstruction is I prefer the biological reconstruction that would stand long term, no need for revision, no need for additional surgeries, and it is durable. We do different types of resection, which is osteoarticular, intercalary, and the whole bone reconstruction. It depends on the size and level of resection, resources available, and surgeon preferences. Allograft, we have for the biological, we have the allografts, autografts, bone transport, and endoprothetic replacement. Allografts, they are from bone banks, and they're very durable and very biological, but they have their problems. Autografts from the patient's same host bone, and they can be durable, but more morbidity and comorbidities. Biological reconstruction is either with thermal, with high heat or low heat. High heat is autoclaving and irradiation, and low heat and extracorporeal radiation. The freezing is using the liquid nitrogen, and it's very successful in tumor recycling. Another technique that the Japanese have invented years before, the distraction osteogenesis, where I can grow the bone from another side and from the physis, which is working really fine. Okay. Endoprothetic replacement is the custom-made design, which is the older one. We have a template for the patient, but now we have the modular systems that are fitting for the patient. Okay, these are the expandable prostheses, as I told you before, that can expand. This is a combination of allo-prosthesis composite, where I combine both biological and metallurgic ones. One thing I need you to understand is the rotation plasty. Rotation plasty has a very diversified concept in our literature. It's either conceived as limb salvage surgery or intercalary amputation. Okay, it's called Van Ness rotation plasty, where I rotate the foot and I put the heel instead of the knee, and the foot will be the prosthesis, and that's how it looks like. It's mutilating. It's not psychologically accepted by many patients, but to be honest, one of the best in functions in terms of if I need to do an amputation. So the limitation should be if there is more neurovascular structure or any limitation of that prohibits limb salvage surgery. Some relative contraindication like pulmonary metastasis and fracture. Functional elevation, we evaluated by a functional scoring system from the Musculoskeletal Tumor Society. In conclusion, I should have limb salvage for malignant tumors surrounded with complication. Yes, it is surrounded with complication, but good functional outcome and successful cases justifies its continued use. On the other hand, amputation still can be used as an option in some cases. It should always be present in the armamentarium of orthopedic oncologists. Thank you so much for your attention. Have a good day.